Clinical Consultation Network. Really appreciate you being here today. I have my compadre here, Michelle Bagby, and my other compadre, Trey King, here with me. And we have been here at the Mental Health Cooperative in Nashville, Tennessee today doing a presentation about the same thing we're going to talk about today on the Clinical Consultation Network. And okay, somebody was suggesting that we work on the echo issue. If we're having an echo, Michelle's trying to fix that right now. I'm going to proceed though. Somebody did point out to me a moment ago that today is Mardi Gras Day. And so for those of you who don't know about it, Matt Owen, who is one of the, is the recreational therapist at the Harold Jordan Center, tonight is going to do his, I'm not going to say it's his debut. He's actually kind of a rock star, but he is, he's got a gig at the Acme Feed and Seed tonight. So if you're interested in doing something on Mardi Gras, Fat Tuesday, just Fat Tuesday, right? If you're interested in doing something on Fat Tuesday, that might be a good thing for you to drop in on. Now, so what we want to talk about today is something that is near and dear to my heart. I'm a member. I'm actually the treasurer of the National Association for Dual Diagnosis. It's not really called the National Association for Dual Diagnosis anymore. It's an organization for people with co-occurring mental health disorders and intellectual disability. A lot of organizations have changed. They've kept their acronym, but they've changed their name or changed their way of communicating that. So they don't use the acronym to represent words anymore. They're just basically sticking with that, but they have a different way of explaining who they are. But it's really basically doing the same thing. And I think it's important to review and maybe consider a little bit some things related to this because it's one of those circumstances where I think we can lose sight of it, and that a lot of people, probably a lot of people on the phone know a lot about this, but a lot of other people don't know much about it. And so when you're communicating it to other people, you want to make sure that you're getting a message out there that they can understand and that they really clearly get all of the angles associated with making psychiatric diagnoses for people with intellectual developmental disabilities. So I'm going to just go through a few things. Some of it might feel a little bit like review, but that's not going to be a horrible thing. And then we'll launch into a few diagnoses and discuss them. And I hope people will jump in today and get a little bit of their own input. If you have observed someone with any of the diagnoses that I'm talking about, or if it rings a bell with somebody that you've worked with or whatever, if you have a question related to whomever you might be working with, that you would ask those things and that we could have a little bit of discussion surrounding that. So please jump in. Our objectives for today, I'm going to go through just a quick definition here of intellectual developmental disability. It occurred to me that everybody may not fully understand the distinction between an intellectual and a developmental disability and the similarity of the two diagnoses as well. So I'm going to just try to make sure that everybody clearly has that definition in mind. Intellectual developmental disabilities gets thrown around a lot, and at some point it becomes a little bit perfunctory, so I just want to make sure we return to actual definitions of those. And then we're going to discuss IDD and co-occurring mental health disorders. We've selected a few diagnoses to work with, and we're going to talk some about the Diagnostic Manual Intellectual Disability 2, which is a manual that's put out by the NAD organization. Gives alternative diagnostic criteria for people with IDD, so we're going to talk a little bit about that and talk about some differential thoughts as it relates to particular diagnoses. And then review important factors for effective treatment, share information regarding our DIDD system of care. Probably, we may share that quickly. We're going to get the PowerPoint out to everybody so you can have this and have those resources, which are at the end, and any additional resources that we may have. So those will be our objectives for today. So, DSM-5, we know that intellectual disability is actually the diagnosis in DSM-5 is intellectual developmental disorder, and there it is composed of deficits in intellectual functioning. So that's reasoning, problem solving, planning, abstract thinking, and judgment. Those are the types of things that are being assessed with an IQ test. And so when a person has an IQ of 70 or below, so that's the average score on an IQ test is 100, 70 or below is intellectually disabled. And so that is one of the criteria that's to be used, but that is to be combined with the person's difficulties in adaptive behavior functioning. So you can't just say, well, they got a low IQ, that means that they have an intellectual disability. Some people may have adaptive behavior functioning that is greater than their intellectual functioning. Some people may have adaptive functioning that's lower than their intellectual functioning. And so that is something that must also be looked at. And a person who with adaptive behavior, difficulties in communication, difficulties in taking care of daily activities of daily living, like, making up their bed or I don't know, a lot of people don't make up their bed, but, they might just choose not to make up their bed, but, people who have difficulty doing those things, cooking their meals, taking care of their self-care, other things of that nature, those will be the deficits in adaptive functioning, and that's an equal part of that diagnosis. And then the onset has to start during the childhood years. So it starts in early life, before the age of 18. Sometimes we say, for developmental disabilities, we actually say before the age of 22. Those are arbitrary to some degree, not completely arbitrary, but they're a little bit arbitrary in that we're selecting an age that we think a person has reached adulthood, essentially, and that we wouldn't consider it an onset during childhood. So that is the basic definition of what we're talking about when we say intellectual disability, not necessarily developmental disability at this juncture. The other point that I want to make, and I think this is an important point whenever you talk to other people about intellectual disabilities, is that you make clear to them that everybody with intellectual and developmental disabilities is not the same. They're different. They have, some people, most people with intellectual disability are in the mild range of intellectual disability. Very difficult, a lot of times, to distinguish from a typical person. And so if a person has in mind somebody in the profound range, somebody who has, basically has to be taken care of most of the time, if they have that in mind when you use the term intellectual disability, but you're actually talking about somebody in the mild range of intellectual disability, they're going to have a whole wrong impression of how to approach that person, what to think about with that person, and, what their expectations for that person would be. So to the extent that you use these labels, and there are significant weaknesses that I'll talk about later in using these labels at all, but to the extent that we use those to communicate, you have to be very clear what it is that you're communicating. And by the way, Trey and Michelle are going to enter at a certain point here and be part of this presentation. They're not just here observing me. Okay. But it'll be a little bit later. All right. So intellectual and developmental disabilities. This developmental disability, so when we talk about developmental disability, we conflate these terms a lot. When we talk about a developmental disability, it basically is a person who has functional limitations in those areas that I was talking about, but they don't have a cognitive disability. I started to say they may not, but they don't necessarily have a cognitive disability. Intellectual disability is a part of developmental disabilities, but I'm going to show you a slide in just a second that illustrates the relationship between the two. Some developmental disabilities are strictly physical, or maybe they do have something to do with how a person thinks or processes things, but doesn't necessarily mean that they have a deficit in problem solving or a deficit in intellectual functioning. So for example, autism spectrum disorder. Now, some people with autism spectrum disorder may also have intellectual disability, but there are a lot of people with autism spectrum disorder who have an IQ that is really high. There's no limit to how high an IQ. Some people say Bill Gates is probably a person with an autism spectrum disorder, very intelligent person. I had a guy that I worked with at Vanderbilt. I had several people that I worked with at Vanderbilt who had IQs that were well above 100 that had an autism spectrum disorder. And I'm going to talk about in a moment the way that that affected their communication. But it was, it doesn't mean that they have an intellectual disability just because they have a developmental disability. It also occurs during childhood before age 22, but it is not necessarily something that it affects a person's intellectual function. The other diagnosis that I'll mention there is cerebral palsy. In the talk that I just did with the mental health co-op, I brought up, I don't know if people have seen the movie The Music Within. If not, I highly recommend it because there are a couple of great things that are communicated in that movie. One is that people with disabilities really can do stuff, okay, that they can accomplish things, that they can work. And so that was all about a fellow that had been in the Vietnam War, has had a hearing impairment, and he came back and he was able to develop a job training program and work real hard on the individuals, the Americans with Disabilities Act, the ADA. I don't know why I had trouble calling that up because I talk about it a lot, but the Americans with Disabilities Act in 1990, I think it was, and so it was a movie all about that, but he came back and he met up with this guy with cerebral palsy, and it turned out that his particular hearing impairment he couldn't understand what most people said, but he could understand this guy who had cerebral palsy. And so they developed a friendship. But that guy that he met, he did not have any kind of intellectual disability. He was a person, he had a substantial physical disability that required him to use a wheelchair, but he didn't have a cognitive disability. And so the point is, it's not to say good, bad, indifferent. It's really just to say that there are all different kinds of people that have these different sorts of disabilities that we're talking about.
Hey, Bruce.
Yes.
Hi, this is Felita.
Yes.
And I just wanted to share that I really appreciate you pointing out these different scenarios or combinations of disabilities that are captured in the population we're talking about here. In a previous life, I had the pleasure of working at Tennessee Rehabilitation Center.
Yeah.
And we saw they serve all manner of different types of disabilities, and it really was, for me in my position working reception and admissions, I would have the clients approach me at different points throughout the day because they needed to see their case manager to whom they were assigned. And often was the case that just going by appearances and conversation, it was really not apparent at all that I was talking with someone who had any kind of a disability.
Right.
So that I wanted to throw that out there, and also to ask about how traumatic brain injury falls into what you're describing. If you've got someone who is older than the age of 18 who has experienced a traumatic brain injury and may still have like a good deal of previous cognitive functioning, but physical ability is compromised, would that group of folks fall into this group, or is that a different?
Well, this goes back to this, I'm not going to say entirely arbitrary, just somewhat arbitrary age at which people qualify for services. So you have the traumatic brain injury the day before your 22nd birthday, you may have a developmental disability. If you have a traumatic brain injury the day after, you don't have a developmental disability. You see where I say that that's somewhat arbitrary. I mean, it's very difficult to draw a line like that, but we're talking more about eligibility for services there than we are really functionally what's going on. And so a lot of people with traumatic brain injury have very similar characteristics to some of the things that I'm talking about here. The difference may be, and it may be really significant when they have that traumatic brain injury, because if you had it at a certain point in development, it may have had certain effects that are different from what it would have had at a later point in development. So those would be the few considerations. I'm really glad you brought the Tennessee Rehabilitation Center into this, because one of the points I really wanted to make is that we think a lot of times that the universe is the people who are in services or in our services. We serve about 7,000 people through DIDD. I think a fair number of them probably went to the Tennessee Rehabilitation Center, but probably a smaller percentage than of the rest of people with intellectual and developmental disabilities, because we serve about 7,000, maybe 2,500 to 3,000. I'm not sure exactly how many people are served in ECF right now, but maybe about, let's just say it's 3,000. Let's just say there are 10,000 people in services right now in Tennessee. If I go to the IQ test and I say, okay, 2.2% of those score at 70 or below on an IQ test, that means there are 130,000 people with intellectual disability. I'm not even including developmental disabilities in that. So there are a lot of people who may have an intellectual or developmental disability who never enter a service system. That they might go to, and a lot of people go to Tennessee Rehabilitation Center, and then they live a fairly typical life after that. It's important to really understand that, because when you're placing limits on people, say, well, no, the truth of it is a lot of people really accomplish quite a bit. It's amazing. And I'm sure you saw that during the time that you were there at TRC.
Bruce, would you agree that developmental disability is primarily, as you pointed out earlier, an administrative classification for purposes of service qualification?
Yes, sir.
It's not a clinical diagnosis.
Right. That's correct. It is not a DSM diagnosis. You won't find that in the DSM-5. You won't find that in the DMID-2. You won't find it anywhere. It is a purely an administrative classification. Thank you for pointing that out.
You bet.
That was, by the way, everyone, that was none other than Rick Amato, who was he was our guest a few weeks ago, and he's been trolling. Is that trolling? What are you doing? He's lurking. Okay, that's Rick and I are in the older generation, so he used the term lurking earlier to describe what he's been doing. But he's been listening in, and I encouraged him today to jump in when he had a comment, so I'm glad he did. Autism spectrum disorders, really, yeah, I think it's really important. I know we've seen probably a lot of people with autism spectrum disorders, but it's really a good idea sometimes to return back to what are some of the basic characteristics that we're looking to in a person with autism spectrum disorder. And again, I want to point out that there is a broad range of people who now qualify for this diagnosis. And when we talk about it being a spectrum, that means basically you could be sort of somewhat autistic, or you could be, have a really a lot of characteristics of autism. And so all of those are somewhere on this spectrum. And so you have a very diverse population. I'm going to talk about that in just a minute, but you see difficulties in social, emotional reciprocity. So I was thinking about this a little earlier, and there was a fellow that I worked with when I was at Vanderbilt, and he had a real hard time reading social cues. And there's actually some cool research out there, and I need to look this back up again because I don't have the specific reference for it right now, but they tested kids with autism versus kids with typical functioning kids. And of course, kids learn to make eye contact, in communication. That's an important part of communication, right? That we make eye contact, we look at people, if you're doing a presentation, you're making eye contact with people in the audience. But what they found was, it was really interesting that as these children were learning to speak, they focused a lot on the caregiver's mouth rather than on their eyes. So where a typical kid is going to focus on the eyes and there's going to be communication that comes from that, a person with autism might have a tendency to really focus on the mouth. And one of the reasons they focus on the mouth is, to them, it makes sense. It's where the sound is coming from. So that's where I'm focusing. But it does impair your learning of communication as a result of that. And it impairs. I wrote an article a few weeks ago about blind spots. This can be one of the real blind spots that a person with autism can have, is they might not be able to recognize different cues, social cues that are going on. And so it's really important to recognize that sometimes characteristic of autism spectrum disorder. I gave the example of a fellow I worked with when I was at Vanderbilt. He was really, a guy with a very intelligent guy, had an autism spectrum disorder. But at the end of our sessions, he didn't know when it was time to leave. He was just clueless. And, I don't want to run people out of my office. I'm a pretty nice guy. I try to help people as long as I can, but at some point I've got another appointment coming in and I've got to be able to have him leave, and then, I'll schedule another appointment with him. But he could not read any of the typical cues in doing that. And, sometimes I would get up and I'd open the door and he still wouldn't recognize that it was time for him to leave. And so eventually I had to work my way toward a real, discreet kind of signal to him that this is when it's time to leave. When this bell goes off, it's time to leave. Or when this timer goes off. And so that is just one of those characteristics you want to think about. The deficits in communication, nonverbal communication behavior. So just talking about eye contact, body language, expression. You may not see those things in a person with autism spectrum. And so you're gonna be trying to communicate, and you're not going to get the feedback in those physical ways that you typically would think, perhaps. And I was, that is true of people across the spectrum typically. But the other part of this is that I've found that even when people can communicate with words fairly well, that a lot of times getting in touch with and helping others understand their emotional state is really difficult. And you can see where this contributes to a tendency to really have some emotional dysregulation, because people are, I haven't shown, I haven't displayed to others how I'm feeling at this moment. And then suddenly it's like I can't hold the lid on this any longer, and it blows up. And that's where people describe it. A lot of times they'll say, "Oh, this just came out of the blue. We don't know what happened with this guy." And maybe it could have been something sensory going on in the environment that brought this up. But and we'll talk about that in just a moment. But it's you can start to put together the two and two of how these things happen with a person with autism spectrum disorder. This slide just kind of demonstrates for you a little bit of how this is on a continuum. So toward the left end of the continuum here, you have people who don't do well on test of intelligence, have a much greater difficulty with communication, because communication can be absent sometimes in these folks. And let me restate that. I don't want to say it's absent. I want to say vocal communication or communication with words may be absent, but everybody communicates, right? So, but they have a greater difficulty getting a message across, sometimes because they might not have real good speech, or they might not have any speech at all. And so that's one of the primary ways people communicate. That makes it difficult. Greater tendency to display unusual behavior, although, and it says stereotypes here, it's supposed to say stereotypies, which is, some of the movements that you see people do from time to time, like flapping of the hands, jumping around, or spinning in circles, other things of that nature, maybe stereotypies that a person has. You'll see a greater tendency for people at this end of the continuum. But I'm going to tell you this, I have seen people with really highly developed cognitive ability who do those things as well. And so you'll sometimes see those characteristics, although sometimes you're able to kind of hold the lid on those a little bit more. And then you're going to be more likely to see intellectual and developmental disability in that group. Toward the other end of the continuum are people who perform in a typical to exceptional range on tests of intelligence. Been a lot of people across history that have people in historical figures who have autism spectrum disorder, or retrospectively, we didn't have the diagnosis at the time, retrospectively were thought to have it. Mark Twain was one. I wish I'd brought this up earlier because he's a fascinating figure if you study his life. But one of the interesting characteristics of him, and we talk about this being a developmental disability, because he was obviously brilliant at the writing that he did and the way he was able to put stories together in different parts of the social fabric that was out there. And he was very funny. He'd do shows where he would go and talk to people, and it'd be very funny. But one of the interesting things, just to think about, his wife's nickname for him was "You." That was her nickname for him, and so it just kind of illustrates how it's not an intellectual disability. It's just it's a developmental matter. This autism spectrum disorder, because she saw a lot of his behavior and a lot of the way he was able to. I think that was part of his brilliance, was actually coming at that almost from the perspective of how a child would think about the different things that he's seeing, and how, where when you think about it from that perspective, a lot of things don't make real good sense, and then you turn it around, they really do make great sense. So that is just a little bit of an anecdote there. So that gives you a little bit of a distinction there between people on the autism spectrum. Oh, and Trey just provided me a list of people, famous autistic people in history. There are hundreds of them. I think I'm pretty sure that Bill Gates. Yeah, there's Bill Gates on there. Albert Einstein. Yeah, he was Daryl Hannah. Actually, now I'm going to say the actress from Splash. Does anybody remember that movie? She is stated to have that. So just tons of people. Nikola Tesla, inventor. Lots of famous people that had autism spectrum disorder. Okay. Now I'm turning it over to Michelle. Heard me talk long enough.
I've got a few slides in here. So I wanted to talk with you all a little bit about mental health disorders that can co-occur with individuals with IDD. So as you can see here, 30 to 50% of people with IDD have a co-occurring mental health disorder, which according to research is nearly twice the amount that the general adult population has in terms of co-occurring disorders. Mental health disorders in individuals with IDD are often not recognized or just not treated, which has a tendency to cause the behaviors that are associated to worsen and can lead to more involvement of crisis services, police involvement, and legal charges as well. Part of this comes from the communication deficits that may be involved with their IDD diagnosis. So their inability to describe some of the symptomology for the disorder or their mood. And Bruce brought this up earlier, but the Diagnostic Manual for Intellectual Disability 2, the DMID-2, is a great resource. It kind of covers that for individuals with IDD, often they do not meet the same criteria as what's listed in the DSM-5, and this text actually breaks that down and talks about how the presentation may differ for individuals with IDD in terms of diagnostic criteria. So it's a great resource if you don't have it. It also gives guidelines for how to complete the mental health assessment. So we're going to cover a few of the common co-occurring mental health disorders for individuals with IDD. This is not an all-inclusive list. This is just, we wanted to cover some of the more common ones. So obsessive compulsive disorder, in individuals with IDD, this obviously, like many other disorders, is complicated by any communication deficits they may have. They're not able to talk about their thoughts and fears. They're not able to tell you why the compulsions exist. They're not able to identify that they're bothered by the compulsions or the obsessive compulsive. So that's one of the characteristics that kind of impact us for individuals with IDD. oftentimes we see aggression for individuals who have OCD when their rituals are interrupted by caregivers. And if you don't know the history of them having that OCD behavior, then you might not realize that that's what happened in that situation. So knowing the person's history and having that background is very important. I just wanted to point out, too, a lot of times obsessive compulsive behavior is noticed within an autism spectrum disorder, but they can co-occur. They can't have both disorders, so it's important to note that. And then post-traumatic stress disorder, we're going to talk about a little bit, if we get to it, how individuals with IDD have an increased risk for crisis. They have more likelihood that they've encountered adverse childhood experiences and even trauma in some cases. So a PTSD diagnosis is very possible. And this, again, is complicated by the communication deficit. They may not be able to tell you that they've experienced trauma. They may not be able to tell you if they've had flashbacks or nightmares or things like that. And then Bruce has a good story to kind of talk about our next bullet here, which it's important to distinguish with the person's history, something that may be a flashback versus a hallucination. Oftentimes, PTSD symptoms can lead to a diagnosis similar to psychosis. So it's good to distinguish the two, and I will let you tell your Bigfoot story.
Yeah, in fact, I would say it is of extreme importance to distinguish the two. And then it's distinguishable. Now, that's not to say a person couldn't have both of these concerns as well. We don't want diagnostic overshadowing to occur no matter what we're talking about. I'll talk more about diagnostic overshadowing in a moment. That's a little bit of a foreboding of the diagnostic overshadowing discussion. But here's one thing. Probably maybe about 4 to 5% of people with intellectual disability have a psychotic disorder. Now, that is a higher rate than in the typical population. It is certainly more. But you just take a guess to yourself about how many people with IDD take antipsychotic medication. Well, that number is much higher, probably than whatever you thought. It's 30% of people with IDD that take antipsychotic medication. Now, that is a substantial difference, is it not? Why does this happen? Well, we're not really treating, in a lot of these cases, a psychotic disorder. We're treating something else. We may be treating behavior. We may be treating symptoms of post-traumatic stress disorder for a lot of these folks. So we know that 70% of people with IDD have had an adverse childhood experience. And I'm going to suggest that that number, though found through a recent ACEs study, adverse childhood experiences, it might still be low, that we're not getting all the information about that, because people with IDD often experience these things, and there's a fairly high prevalence of post-traumatic stress disorder in this population. But some of the ways the symptoms get confused is like with this one story that I heard a few months ago. Actually, Rick, you and I were together when we heard this story about someone who reported that she had been raped by Bigfoot. Now, immediately people leap to, this sounds like delusional thinking. This sounds like, this person hallucinating and reporting an hallucination that they were having, that they were raped by Bigfoot. But as it turned out, this person was trying to tell people that she had been raped by somebody who was really hairy. And that was her way of putting it out there. And so sometimes a person with disabilities, because the way they communicate, may have a different way of thinking about that, or may describe it in a very bizarre or unusual way, but it may relate back to an actual experience. So it's very, very important to consider that as a differential anytime you're making a psychotic diagnosis for someone.
So as you can see on the slide, there are several other presentations that PTSD might come across in terms of individuals with IDD, that the reenactment, the reactivity that can come across as self-injury or aggression, sleep disturbances, but a lot of these same symptoms can also be related to another medical disorder or their IDD. So it's important, again, to know the person's history and to make sure that we're really exploring those things to rule this out. So bipolar 1 mania, as it differs with children, similar to IDD, it can present as irritable mood, sleep disturbances, increased rituals, increased sexual behavior. A lot of times there's fewer cognitive symptoms. For individuals with IDD, you won't get that inflated self-esteem, that pressured speech, especially if there's communication deficits. So it's just important to have a credible informant in those situations when you encounter people that maybe experience mania, to find out if that is typical behavior for them or if this is out of the ordinary. And schizophrenia, we kind of talked about psychosis a little bit already. There are a lot of complicating factors that tend to result in a diagnosis of psychosis that may or may not be appropriate. But like we talked about with the trauma-related experiences, medication side effects, medical issues that are unresolved can also mimic psychosis. So a UTI can cause delusional thinking if it's left untreated. So things like that are important to recognize with an individual with IDD. Major depressive disorder, this is another one that's missed pretty frequently, especially with the communication deficits of being able to say they're sad. It can, again, look like irritability, agitation, have crying. So they're already a pretty isolated bunch, so there's a lot of social and communication deficits that play into this. Suicidal ideation can be difficult to detect, especially if they're not able to verbally express that. It may come across as self-injury. It may come across as running into traffic, other risky behavior that puts them in imminent risk of harm. So it's important, again, on this one to rule out unresolved medical problems because you can see a lot of the same presentation from those as well.
So we spent this time talking about diagnosis and what it means, and how to make those diagnoses in people with intellectual developmental disabilities. I don't know, we can go in great detail with it, but anytime I talk about diagnoses, I also want to talk about some of the pitfalls that go along with making diagnoses and labeling people. What happens when we do that, and what are the tendencies really? Is that when we do dialectical behavior therapy, we talk about what are there's always another side to everything, right? And so there's the quasi-science of making diagnoses, and then there's also this other side of it, which is that there are certain things that happen with that we don't intend, that we really have to discipline ourselves and watch. And one of those is faulty expectations. I was telling a story, and actually several months ago, we had a friend of mine who came on to the Clinical Consultation Network, told the story about him learning to drive a tractor. And he's a guy with an autism spectrum disorder. I'm going to say he's probably not a person really with a severe intellectual disability. He's probably in the mild range of intellectual disability. But he came to my property. We sometimes invite people over to ride horses at my property. We do a lot of fun things, and then he got interested in my farm equipment. He's very interested in equipment. Actually, he can draw these outstanding pictures of different types of equipment, and he's really into the nomenclature. For those of you who aren't in the military, nomenclature means the number, the name of the equipment and all this kind of thing, and he loves trucks and all this kind of thing, but he was really interested in a tractor, and he got so interested he asked, could he get up on the tractor, could he start the tractor and these kinds of things, and I'm getting really nervous. I've worked with people with disabilities a long time, but I also have this sense of liability that underlies everything, and there's a little bit of fear in me and having him, operate the equipment. But what I decided I would do is kind of slowly work him up and just do different things. The first time I just sit on the tractor, then I had him, the next time he came, I let him start the tractor, and then I said, well, all right, I'll tell you what, I'm going to back it out here for you, and then I'm going to let you drive it a little bit in first gear. First gear on a tractor is really slow, so I was able to walk alongside him and interrupt anything that might happen. Well, over several times in coming, we were able to work him up, and now he has actually reached the level where he drives that tractor without any supervision. He bush hogs my pasture. And the point I'm making about this is I could have taken that autism spectrum, so I could take his intellectual disability diagnosis, either of those, and really said, well, this is just not something that's for him. But yet, he was able to learn to do those things. So I might have unduly limited him because of the diagnosis that he had. That is very, very important to think about, that you might be limiting someone. The other aspect of this, of course, is we want to right-size our expectations. It's also not good to be in an environment where people are expecting more of you than you're able to do. And so if I can just give a quick analogy here, if I were to go onto a basketball court with NBA players, I'd be completely out of my element there. The expectations for me would be too high. I would not want to find myself in that situation because the score, my team would be all over me about letting people score and, not being able to compete in that type of environment. I just think that's important to keep in mind because, we certainly want to help people with disabilities achieve everything that they can, and yet we want to try to right-size expectations so that we don't put them in a position where, it's more than they can handle. Now, do we all get in situations that are a little bit more than we can handle time to time? Yes, and that's how we learn. So, that advice has to be taken with a grain of salt, but, sometimes we might know if we're entering something that might be well above what somebody is able to accomplish. Diagnostic overshadowing, such a key thing. It's really one of the primary reasons that the MAD organization I talked about earlier exists. Diagnostic overshadowing is where we take that IDD diagnosis and basically say that defines this person. So they're not a person with personal characteristics. They're not a person that could have other psychiatric diagnoses or other types of issues that are creating problems that they may be having. We're just attributing it all to the IDD diagnosis, and that's a pitfall of using diagnoses. And Rick, you brought up this point a little earlier. I often wonder if the ID diagnosis is even helpful, other than identifying the person's eligibility for services, or a developmental disability diagnosis. False attributions, assuming challenging behavior is all because of the ID. Challenging behavior is not a core feature of intellectual disability. So we said 35 to 50% of people with IDD or ID do have a co-occurring mental health disorder or behavior problem. Well, that means 50 to 65% of people do not. So you can't say that ID is causal of a behavior problem. It's other factors. There are other factors involved. There are conditions that people are placed in that cause them to have behavior problems. There are times where people have expectations that are too high or too low of someone that cause them to engage in problem behavior. There are, circumstances where somebody is not getting a need met that they engage in problem behavior. It's not because of their ID. It's because of those other factors. Interventions have to be directed toward dealing with the cause of the behavior. Okay. This slide is somewhat just kind of a capsule summary of what I just said. And we're going to send this out to you so you can review that later. Oh, I want to mention the executive functioning program. How much time do I have? We got 10 minutes left. Okay, we're done. Okay. I wanted to mention, I don't know if I've told this story here before. I tell this story a lot to police officers, and I'm actually talking about this executive functioning problem. So when I talk to police officers, one of the great concerns is about how, and let me tell you something. I see a lot of circumstances where police officers do a great job of working with people with disabilities. They modify what they do, and they really, I've seen police officers sitting down on a curb with somebody and talking to them, and I've seen them doing a lot of really positive things with people with disabilities. From time to time you'll see a video that goes out and goes viral because there's a police officer who's doing a great job. And I want to make sure that police officers know a little bit about people with disabilities so that they can they can do those types of interventions and know how and when those might be appropriate. But I was telling a story of a fellow from Baltimore, Maryland. His name is Robert Ethan Saylor, and he had been very excited. He was a person with Down syndrome. He had been very excited about going to see the movie Zero Dark 30 several years ago. I think it was 2011 when that movie came out. And I could be wrong about the date, but somewhere around that date. In any case, he was excited about this movie. He went to see it with a caregiver, and then at the end of the movie, he didn't want to leave the theater. And in fact, he wanted us to watch the movie again. Well, the management of the theater was upset about this, and so they said, you can't stay in the movie. You can pay to see the movie again. And so he calls the security guards. The security guards start pressing in and want him to get out of the theater. And the more they press in, the more he resists. So eventually they have to physically, take charge of the situation. They put handcuffs on him. At some point in the transition, I mean, it's easy to imagine how this happens, and I don't know all the details, so I just want to be clear about that. But he ends up on the floor, and he ends up suffocating from what's called positional asphyxiation. So when a person is lying in a prone position on the floor, there's a great risk of something called positional asphyxiation because the position that's in, they can't breathe. And so that happened to him, and he died. And a little bit of understanding about this concept of executive functioning. This is not. I'm not doing Monday morning. Well, I'm doing a little bit of Monday morning quarterbacking, but I'm not trying to be critical of people who might have been doing the best they could under circumstance. Although I am saying we don't want that to happen again, right? And a little bit of understanding about this concept of executive functioning problems could have really helped there. Because executive functioning problems is where I hear what you're saying. Maybe I'm even somewhat cognizant, showing you that I'm cognizant of what you're saying or what you're asking me to do, but I do not move in that direction. And a lot of people with Down syndrome, a lot of people with autism spectrum disorders, a lot of people with intellectual disability in general do have these executive functioning problems. And so if you're a police officer, one of the things you expect is people are going to respond to my commands, right? And if you don't respond, then we have a way of dealing with that. This executive, what I've found with a lot of people, when you back off of that, when you say, okay, make a request, you back away from them rather than pressing in, you find that they often respond and do better. And to tell the truth, given the outcome of the situation, I'm sure those security guards and management wish that they had just paid for him to stay for another movie. But they might have been even successful in implementing what they wanted to do had they used an approach like that. Emotional dysregulation is another big piece of this. Where you see people with autism spectrum disorders, people with borderline personality disorders. So when PTSD has reached a point that it affects a person's personality, they have borderline personality disorder, and you'll see a lot of emotional dysregulation for those folks. What they need help with is how to manage that emotion, and that is that's a difficult thing because like I was talking about the person with autism spectrum disorder, they may not notice you may not notice any signs that they're even upset until they get to the point of that it's blowing up. I was talking about the fellow that learned to drive a tractor. My tractor for a while had a problem of overheating. This was one of the ways I learned to help him kind of gauge where he was, because when the tractor would overheat, he'd have to recognize that. We'd have to take corrective action under that circumstance. That was the way I taught him the concept of being able to self-assess where he is and to be able to take appropriate action when that occurs. Okay. I just want to, on this slide, I've already talked about trauma and adverse experiences. The other thing I really want to hit is medical problems. So medical problems are a key issue that a lot of people face. Constipation, and sometimes people get really constipated. I may have told the story before about a fellow with autism spectrum disorder that I was working with, and he had to be in the hospital, and I was at the hospital with him, and he had a BM while he was at the hospital. BM, bowel movement. I'm sorry, I know this is really gross, but I do need to tell this because it's so important. He had a bowel movement, and that thing was that big around. And it was let's see, how can I, very long. Let's just say that. I mean, that is a serious issue of constipation and a lot of pain coming from that. And when you have that pain, it can stimulate, some of the things that we call problem behavior. So very important. I have another story that I don't have time to tell about that, but just suffice to say, think about medical problems. Really, think about constipation. Think about dehydration. Think about urinary tract infections. Other things like that, gallbladder disease, other things like that may be causing someone to respond in the ways they are, particularly when something comes up suddenly. Just consider all the factors that might have an impact on something. You're going to get this. I'm going to let you review the slide on your own. And I'm going to let you review this slide and let's just, I tell you what, we've got a lot of information here. Everybody knows how to get in touch with the IDD, all that kind of thing. I'm just going to pause and ask if there are any comments or questions based on what we've talked about. I have, once again, utilized all of the time, frittered away the whole hour, and have still not finished what I wanted to do. But do you have questions or comments?
It might be interesting for some people to look at the work of Richard Sobsey, S-O-B-S-E-Y, a researcher in Canada in the 80s and 90s, who studied the trauma and abuse in people with intellectual disabilities. And some of his research suggested it was in the 90% or higher range.
Yeah.
And currently, Nora Baladarian on the West Coast, who has a nice website, has made a study of sexual abuse in people with disabilities.
Right.
There's some data on her website. A guy who contributed an awful lot to this conversation, who passed away early, is Herb Lovett.
Right.
Who, his famous line was, a lot of acting out behaviors because that's what people have to do to get us to listen to them.
Yeah. His book was Learning to Listen. That's a seminal book. I highly recommend that book.
Yeah. And I want to add one thing to your list of medical issues, which is low blood sugar or hypoglycemia.
Yeah.
People with low blood sugar have a hair trigger on their reactions. And given the diets that a lot of people with intellectual disabilities are on, because other people are determining what they eat when they eat it, low blood sugar is not at all uncommon. And yet it's rarely identified as a cause of what people are doing.
And a lot of these things are reasons people get on high amounts of psychotropic medication, and it really doesn't even seem to be doing any good. So, that is such a key thing. Dr. Rick Amato, everybody.
There are several medical conditions that
Thanks.
to some of these challenging behaviors. I mean, I've had experiences where people I've worked with in the past have had issues with ear infections or unresolved dental issues that may have not been identified early enough, so those can cause behavior issues as well.
I'm glad you brought dental issues into that, particularly for people who don't communicate with words, that oftentimes you'll see behavior that is basically communicating, my mouth hurts. And you know how it is when you have a toothache, you might really press on it, or you might hit on it a little bit, could be self-injurious behavior, could be masking as basically dental pain. Thank you all for being here. I know we kind of rushed through certain parts of this. This is part of our ongoing discussion here on the Clinical Consultation Network. I'm glad you could join us today. It's been stimulating opportunity to be with you. And so I really thank you so much for being here. We do this every Tuesday at 12:30 Central Time. And, you never know when somebody like the esteemed Dr. Rick Amato might show up. So that's always good. And so please be here with us each Tuesday at 12:30 Central Time. And you can always catch up with our broadcast on the IDD website. And if you go back to the invitation I sent you earlier today, you can reach that website through the link at the bottom of the page. So thank you all for being here. We'll see you next week.